This lecture is a basic analysis of radiographs and the radiographic assessment of bone tumors. There are 6 key components to evaluate when looking at imaging. Age, location of the tumor, which means surface, intermedullary, or epiphyseal, metaphyseal, diaphyseal. The tumor bone tumor interaction, which includes zone of transition, periosteal reaction, or cortical involvement. The actual matrix, or what is the bone tumor making? Is there a soft tissue component that is associated? And then the size and number of lesions. Age is important in the radiographic assessment of bone tumors. It's the first thing we find out about a patient and our first indication as to a differential diagnosis. Age is best thought of in broad categories. Lesions that occur in patients less than 30 or greater than 30. There are a lot of diseases that occur in patients less than 30. The most common primary bone tumor, Osteosarcoma. Second is Ewing sarcoma. In patients greater than 30, the most common primary bone sarcoma is chondrosarcoma. Certainly the most common lesion we see would be metastatic disease. This includes the osteophiles, prostate, thyroid, breast, lung, kidney, but we also lump myeloma and lymphoma into this because of the way they occur. Chordoma, adenomyoma, giant cell tumor, and Paget's disease round out the lesions in patients greater than 30. What about the location? This is a pictorial representation of bone tumors that occur in patients less than 30 and greater than 30. It correlates with the table I showed you earlier. When you do look at these entities, there are correlates in each age range that radiographically may appear similar, but when you look at the age range would give you a different differential diagnosis. The first example is Langerhans cell histiocytosis, or LCH, and myeloma. They both are punched out lesions depicted on this image as a black circle. The process that occurs is usually diaphyseal, and there is not much of a reaction. It looks like the area is just punched out. The histology is obviously quite different. The Langerhans cell is the key player in a Langerhans cell histiocytosis versus a plasma cell in myeloma. But radiographically, these can appear exactly the same. The difference would be a skeletally immature versus skeletally mature patient. Small round blue cell tumor correlate, Ewing sarcoma and lymphoma. In a patient less than 30, you're more likely to see Ewing sarcoma. And the young bone with its exuberant periosteum responds differently to this small round blue cell tumor than it does lymphoma. In a young patient with a very active periosteum, as the small round blue cell tumor makes its way out of the bone and those little small round blue cells swim out of the Haversian canal system, the periosteum is able to respond. As the periosteum is lifted away from the actual bone, it actually mineralizes quickly, and the tumor tries to spread beyond that, but the periosteum gets pushed away, mineralizes, and this process occurs over and over again to create the Codman Triangle, or the onion skinning we talk about for Ewing sarcoma. In contrast, lymphoma occurs in skeletally mature bone on most occasions, and as those small round blue cell tumors push through the bone itself doesn't do much because the periosteum isn't as excited to react and respond. So you get a really big soft tissue mass with very little destruction of the bone, which is quite characteristic for lymphoma. So both of these small round blue cell tumors create very large periosteal reactions. Another correlate by histology is a cartilage tumor. Osteochondroma typically occurs in a patient less than 30. Chondrosarcoma we see in patients greater than 30. The difference here is that an osteochondroma is confluent with the intermedullary canal. It also is a developmental tumor that occurs as a growth plate rest turns 90 degrees to its normal growth pattern and creates a stalk of bone growing off the bone. A chondrosarcoma occurs later, typically in life, greater than 30 years, and it can arise from an aberrant growth plate or a growth rest that has sat behind as the physis has grown and mineralized. It is an area of unmineralized bone or cartilage. The aneurysmal bone cyst and the giant cell tumor. An ABC can occur in conjunct or as a collision lesion with a giant cell tumor. But both of these tumors expand the bone, create a periosteal response so that the bone actually tries to hold the bone in. They're known as benign aggressive lesions. They're benign, they rarely metastasize, but they are aggressive enough to expand the bone. They aren't so aggressive that they destroy the bone, but create a slow ballooning expansion. Typically, we talk about a giant cell tumor as an epiphyseal lesion, and an aneurysmal bone cyst can occur in the metaphysis or the epiphysis. The difference on imaging an aneurysmal bone cyst may have fluid levels in it or several fluid levels, and a giant cell tumor appears to have no specific matrix. This is just a closer example of the tumors that occur in patients less than 30. One of the key findings is you have a physis here. And an osteosarcoma is usually a metaphyseal tumor. It can spread across the physis. But an epiphyseal lesion that we see in skeletally immature patients is a chondroblastoma, depicted here in the epiphysis of the bone. In patients greater than 30, that similar correlate is a geode. Is obviously not a tumor. It is a crack related to arthritis in which articular fluid creates a fluid-filled cavity within the epiphysis of the bone. Not only is there a location correlate by epiphysis, metaphysis, diaphysis, but there are some tumors that have a predilection for certain bones, and these are three tumors that tend to occur. Majority occur within the tibia: chondromyxoid fibroma, non-ossifying fibroma, and adamantinoma. The chondromyxoid fibroma, seen on the left, is a very aggressive tumor. It's one of those benign aggressive, locally aggressive tumors that rarely metastasizes. It looks like a shark bite or a cookie bite just taken out of the bone. A non-ossifying fibroma, seen in the upper middle part of the slide, is a lesion that is mostly cortically based, has this slightly expansile appearance, and may ossify. So you have a non-ossifying fibroma that is undergoing ossification, or an ossifying, non-ossifying fibroma, which is a fibrous lesion, usually asymptomatic. And then an adamantinoma, which is very common to see in the tibia. It is a cortically based lesion, sometimes described with a soap bubble type appearance to it. These lesions can be determined by histology if necessary, with a very, very different histology per each of them. In the bottom left, the chondromyxoid fibroma has chondroid, myxoid, and fibrous parts to it. So there are three different tumor types on histology that sort of oppose or are juxtaposed. A non-ossifying fibroma is a bland, benign, fibrous lesion. And in the bottom right, an adamantinoma is a tumor that very much has nests and glands appearing in it, different than the nests and glands seen in metastatic tumors. For tumors by location, epiphysis, metaphysis, diaphysis, flat bone, spine, sacrum, surface are the main location we're discussing. We can also think about surface versus intramedullary. The most common tumors by the epiphyseal location: chondroblastoma, giant cell tumor, clear cell chondrosarcoma. Chondroblastoma typically occurs in the skeletally immature patient. Giant cell tumor in the skeletally mature patient. Clear cell chondrosarcoma is more commonly in the skeletally mature patient and is a very rare tumor. Metaphyseal lesions, osteosarcomas, chondrosarcomas, and METs are the most common. One helpful way to remember the diaphyseal tumors by location is AEIOU and sometimes Y. Adamantinoma, as we have discussed, commonly occurs in the tibia, cortically based soap bubble appearing lesion. Eosinophilic granuloma is a punched out lesion of bone. Infection can of course occur anywhere, but is common to find in the diaphyseal portion of a bone. Osteoid osteoma and osteoblastoma. One way to differentiate them is by size. Osteoid osteoma is typically less than 2 centimeters. Osteoblastoma greater than 2 centimeters. Ewing sarcoma and fibrous dysplasia. The spine can be divided into anterior and posterior elements. We commonly see giant cell tumor of bone and metastases in the anterior elements, mostly the vertebral body, and posterior elements, osteosarcoma, osteoblastoma, and aneurysmal bone cyst. The picture seen here is an osteoblastoma. Sacrum is a location where we see ABCGCT. These it's common for them to be a collision lesion combined. Chordoma or metastatic disease. Flat bones include the skull, the sternum, the rib cage, the scapula, and the pelvis. As we think of the flat bones, there are tumors more common to occur in this location. Hemangioma, fibrous dysplasia, chondrosarcoma, Paget's disease, Ewing sarcoma, and METS. If we harken back to our ages, if we have a flat bone lesion that appears consistent with the primary bone sarcoma, a patient younger than 30 is more likely to have Ewing sarcoma. A patient older than 30 is more likely to have a chondrosarcoma. The tumor-bone interaction includes a zone of transition, periosteal reaction, cortical involvement. Tumor-bone interaction, as described by Lodwick, helps describe the zone of transition. It's not important to understand the type and number more than it is to understand the progression from a benign entity to a highly malignant entity. This is an example of the tumor-bone interaction and zone of transition and how tumors progress and are more aggressive. Geographic lesions, as seen here, progress from sclerotic borders, which show that the tumor is old, walled off. There's been enough time that the body has healed, created a very firm sclerotic rim around the tumor, versus a distinct tumor, which does have a border where you can see the transition distinctly from the lesion to the bone, moving on to an indistinct border. I show this by red arrows because it's much more difficult to see than the previous tumors. The next level of aggressivity is the moth-eaten bone. This is commonly used to describe metastatic bone disease. The tumor eats small pits and holes in the bone as it is making its way out of the bone. The bone is very slow if there is any response, and so you only see the response of the tumor within the tumor-bone interaction. The term moth-eaten is exactly that. It's described from moths eating clothes. The moths eat holes in the clothes, leaving some areas normal and leaving some areas with these small areas removed within the fabric. Progressing further is the destructive appearance. You can see here that the tumor is moving so quickly that there's barely any response from the bone. So again, in the tumor-bone-tumor interaction here, the tumor is so aggressive that the bone has no time to respond. The ultimate example of a zone of transition is actually when there is no zone of transition or the tumor is radiographically occult. This occurs when a tumor is so aggressive, like a small round blue cell tumor, that it moves so quickly that the bone has zero chance to respond. The tumor moves past the bone, creating a huge soft tissue mass, seen on the MRI scan to the right. The yellow arrow showing the intramedullary extent and the red arrow showing the soft tissue mass extending out of the bone. But the bone has had zero chance to respond, showing no signs of any foul play. Tumor-bone bone-tumor interaction is also expressed in the periosteal reaction. You can see on the far left how there is a single line of response as characterized by stress fracture or osteosarcoma. As the tumor progresses, we see multiple lines, hair-on-end pattern, or the Codman Triangle, suggesting increasing aggressivity of the tumor, progressing to an entity like Ewing sarcoma. The single lamellation line is most commonly seen with a stress fracture or a lower aggressive entity like an osteosarcoma, which has no metastatic potential. As we talked about for the small round blue cell tumor in a patient with a robust periosteum, we see a much more exuberant response known as onion skinning. As the tumor pushes and expands the periosteum heals And as this process continues, a multi-layer lamellation occurs like onion skinning, just like an onion forms, seen in the bottom right-hand image here. The hair-on-end pattern occurs when the Sharpie's fibers receive stimulation and the mineralization occurs at a 90-degree angle to the bone as opposed to along the lines of the bone. Further, the spiculated periosteal reaction continues to show more evidence of aggressiveness. The perpendicular hair-on-end pattern or the divergent sunburst pattern would suggest Ewing sarcoma or osteosarcoma. The linear spicules of new bone form along the newly formed vascular channels as the body is trying to heal itself. These Sharpie fibers response creates the hair-on-end and sunburst pattern. It's thought, but not perfectly correlating, that the hair-on-end pattern is more common with the Ewing sarcoma, but can occur in osteosarcoma and Mets. The divergent sunburst pattern is often correlated with the osteosarcoma, but none of these are absolute. The idea is that you understand that a hair-on-end pattern or a sunburst pattern is bad, usually connotating a malignancy. Here's an example of an osteosarcoma where we refer to the plain X-ray, talking about the hair-on-end pattern, which is referring to hair actually standing up from its source, or the sunburst reaction, which is occurring along those Sharpie's fibers mineralizing as those new vascular channels follow the tumor as it is spreading, creating a soft tissue mass outside of the bone. The Codman Triangle occurs where the periosteum lifts just at the origin of the tumor. The periosteum holds on at the origin as it lifts. Sometimes the tumor destroys the new periosteum that has formed, creating an elevated lamellation just at a corner known as Codman's Triangle, described by Codman. This occurs in osteosarcoma, Ewing sarcoma, and osteomyelitis. Again, it's a ubiquitous concept that the periosteum is raised or lifted, creating a triangle. It could occur in many scenarios, but most commonly occurs in these. So to recap, Ewing sarcoma versus osteosarcoma, these are not absolute, but the terms that we commonly apply. Thinking about Ewing sarcoma, onion skinning, and a Codman triangle. For osteosarcoma, the cloud-like osteoid. But both can have the sunburst or hair-on-end pattern. The cortical response. There can be a response that's intracortical. Osteomyelitis, osteodacioma, osteoblastoma, osteofibrous dysplasia, and adamantinoma. Here's an example of an adamantinoma in the middle, where we see that soap bubble appearance running over a long span of the bone. Or the osteodacioma, seen in the upper right-hand corner, where the target lesion is within the cortex. It creates the irritation of the cortex through the prostaglandins, and that creates a unicortical lamellation. There's saucerization, which can occur as out to in. So when a soft tissue mass pushes against the bone, eroding the bone, it creates a saucerization type process. To the far right, the red arrows on the X-ray are showing you how a soft tissue mass pushing against the bone creates scalloping on the outer surface of the cortex as opposed to destruction from centrally to externally. The image in the middle is the MRI scan showing you this soft tissue mass that is beginning to envelop the bone, and as it is losing the confines of the muscle, it is now pushing its way into the bone. The MRI scan to the right shows you this again. You can see the saucerization that is occurring as the soft tissue mass is pushing its way into the bone from external to internal. We can follow one of the rules we like when we ask the question, well, is this even a soft tissue mass that is extending into the bone, or an intramedullary bone mass creating a soft tissue mass? One of the tricks is to outline the tumor and then put your finger in the middle of it. So here I use the yellow line to outline the entire tumor, and then use the red asterisk to show you the middle. And if we put our finger in the middle right where that asterisk is, that's usually where the tumor originates or starts, telling us that this is a soft tissue mass because that's where the central portion of the mass is, pushing its way into the bone as opposed to a central mass extending out. It's unusual for a soft tissue mass to push out eccentrically from the bone. You would expect that a soft tissue mass emanating from the bone probably will be circumferential. The term punched out for the cortex is referring to myeloma or Langerhans cell histiocytosis. We've discussed that one clue that's helpful in determining this is the skeletal maturity of the patient. A skeletally immature patient typically has a Langerhans cell histiocytosis, seen on the far left in the skeletally immature patient. In the middle and to the far right, we see a punched out lesion in a skeletally mature patient, more likely to be myeloma. Endosteal scalloping refers to the bone tumor bone interaction that occurs within the intramedullary space extending out into the cortex. The actual term scalloping comes from the appearance of a scallop and the undulation of the shell. This is what the appearance actually looks like within the bone. The red arrow shows you a chondrosarcoma, which is where we most commonly refer to endosteal scalloping. We can also see it in an enchondroma. The proximal portion of this lesion has the stippled arcs, rings, and calcifications for the typical matrix we see for cartilage. But where the red arrows are, you can see that the tumor is actually scalloping out or creating an undulation within the bone. To the right, we see this to an even greater extreme where the black arrows are showing you this scalloped appearance as it travels all the way down the bone, as commonly seen in chondrosarcoma. Cortical expansion, neo-corticalization, or ballooning all refer to terms in which the bone expands just like a balloon. The neo-corticalization is the new cortex that forms as the bone expands. This typically occurs in lesions that are benign or benign aggressive, but can be seen in malignant tumors. The lesion to the left is a telangiectatic osteosarcoma. This could be an instance in which the bone grows and expands, but then dedifferentiates, and we begin to see areas where the bone is lost. The lesion in the middle is an aneurysmal bone cyst. You can see it is in a skeletally immature patient. The lesion to far right is a giant cell tumor of bone. In each instance, the bone has expanded or ballooned and then has a cortical response or a new cortex that has formed. What about the matrix? Well, the fourth question that Enneking asks us to consider: location, tumor-bone, bone-tumor interaction, and matrix. Cartilage can be one of the matrices we see. There are different types of cartilaginous matrices: stippled, flocculent, or arcs and rings. And again, it's not as important to remember the particular name, but the appearance. The radiographic correlates to this are the far left, the stippled calcifications. In the center, the flocculent appearing mineralization patterns. And then to the far right, the arcs and rings that make up cartilage. Osseous mineralization is more cloud-like. It actually looks more dense than the cartilage does. The lesion to the left is a young patient who has what looks like clouds. This lesion is so significant it's creating a huge soft tissue matrix that is mineralizing. The lesion to the right shows you that same cloud-like osteoid. You don't see the firm, definitive mineralization lines like you do in cartilage. This is far more amorphous. Ground glass. This is typically a term used for fibrous dysplasia. The image to the left shows you the difference in ground glass and regular glass. The actual process which ground glass is made is that glass is ground, left in its ground state. It's not melted back down to be clear, and then it is crystallized within glass. You can see the difference. You can just kind of see through ground glass, but it's because there's extra glass pieces within it, as opposed to regular glass that you can see straight through. This is reserved typically for fibrous dysplasia. The image here, the X-ray, shows you what we refer to as ground glass, and the reason you see that is the bone in the upper right-hand corner. This is the fibrous matrix that sits in between the cortex. So when you're taking an X-ray, you have the first cortex, the second cortex. Fibrous dysplasia in the middle almost creates half of a cortex, and that's why the bone doesn't have the same crisp appearance. It's almost like it's got this extra layer within it that makes the bone not as translucent, just like ground glass and regular glass. Soft tissue component is important to consider. We've discussed how to determine a soft tissue mass. If you see a soft tissue mass, you draw a circle around it, you put your finger in the middle of it. It should tell you the origin of where it begins. It's not 100%, but it's a good guess. The soft tissue mass can also be evaluated from what the bone matrix looks like. So this is an example of how the soft tissue mass shows the aggressive nature of the tumor. The X-ray to the far right looks pretty normal. The cortex isn't destroyed, but the central image correlating with the plain X-ray shows you that there's a lot more going on. So this is one of those tumors that does not have a zone of transition by a plain X-ray, but has a really big soft tissue mass, characteristic of a small round blue cell tumor. The lesion in the middle shows you that there is an intramedullary component within the bone, and then the soft tissue mass is actually emanating, beginning to be circumferentially. Currently it's eccentric in these images. Again, a soft tissue mass lets you know that this is an increasingly aggressive lesion. The number of lesions is also important to consider. Multiple lytic lesions typically signify Mets, myeloma, Langerhans cell histiocytosis, or brown tumors. Now, brown tumor is not a malignant tumor, but it can be a fulminant process. Let's go through an example. Asking Eneking's 4 question: location, tumor, bone, bone-tumor interaction, and matrix. The first question is the location. There's a metaphyseal bone lesion. What's the tumor doing to the bone, and what's the bone doing to the tumor? Well, the tumor is creating a very large soft tissue mass, as shown by the red arrows, but there is not a significant amount of cortical response. We can still see a pretty good line making up the cortex. This tells us that this is a highly aggressive tumor. What's the matrix? Well, we see a cloud-like osteoid matrix in the metaphyseal part of the bone. This is all occurring in a skeletally immature patient. So, by definition, an osteoid-forming, highly aggressive lesion with a big soft tissue mass, osteosarcoma. Here's another skeletally immature patient. Location, metaphyseal. What's the tumor doing to the bone? What's the bone doing to the tumor? We again see the red arrows showing a soft tissue mass with some response, a Codman's triangle. What's the matrix? Cloud-like osteoid. Again, an aggressive lesion, soft tissue mass, destroying the cortex, cloud-like osteoid in a skeletally immature patient. Diagnosis, osteosarcoma. Location, metaphyseal and diaphyseal. What's the tumor doing to the bone, and what's the bone doing to the tumor? There is a lot of destruction by the tumor here with no response from the bone. The bone is just being erased. And what is the matrix? Well, there's not a good matrix that we see here. This is a skeletally mature patient, and in a skeletally mature patient with a lytic bone lesion, especially a patient over 50, the first consideration should be for metastatic disease. Here are the examples from the picture that I showed you earlier, just giving you a radiographic correlate. For patients younger than 30 years, you can see that this patient is skeletally immature. This is an example of a Langerhans cell histiocytosis, or that punched out lesion of bone. This is a Ewing sarcoma. We see a central lesion in the bone creating a Codman's triangle and onion skinning. This is an osteochondroma. The tumor itself is confluent with the intramedullary canal, creating a cartilaginous surface matrix that matures as the child matures. This is an osteosarcoma. It has that single lamellation line. It's unicortical. It is very well formed, mature bone. And remember that the bone from an osteosarcoma is created as a response to that prostaglandin produced by that intracortical lesion. This is an osteosarcoma of bone, skeletally immature patient, metaphyseal bone forming lesion with a large soft tissue mass, osteosarcoma. This is the aneurysmal bone cyst. The lesion itself is wider than the physis, which is characteristic for an aneurysmal bone cyst. You can barely see the channels of bone within this plain X-ray. An MRI scan would better show all of the fluid levels in an aneurysmal bone cyst. This is a chondroblastoma, an epiphyseal lesion in a skeletally immature patient. The adult corollaries, the patient's greater than 30, punched out lesion, myeloma in a skeletally mature patient. The moth-eaten appearance of metastatic bone disease. We see lesions in the distal femur, proximal tibia, where it looks like a sweater that has been eaten by moths. This is a lymphoma. The bone itself has very little destruction, but there is a circumferential soft tissue mass, letting us know that the zone of transition is minimal on the plain X-ray because the lesion itself is so aggressive that it is blowing past the bone, creating a soft tissue mass. Chondrosarcoma. Here we see the cartilaginous matrix, the flocculent arcs, rings, stipple calcification, the endosteal scalloping, the overall change in the bony architecture. This is characteristic of a chondrosarcoma. In enchondroma, if you cover up the lesion with your hand, the bone itself appears completely normal. We still see the arcs, rings, stipple calcifications consistent with the cartilaginous matrix, but the bone itself appears completely normal around this, which is consistent with an enchondroma. Here's a giant cell tumor of bone. It's on the medial metaphyseal portion of the distal femur. There's a very narrow zone of transition as the lesion extends into the intramedullary space. The bone itself is having neo-corticalization and expansion, all consistent with giant cell tumor of bone. This is a geode. This occurs when arthritis destroys cartilage or a tendon creates an avenue for fluid to travel into the bone. As the bone slowly expands, it creates an osteoarthritic cyst consistent with the appearance of a geode. A geode is a geological finding in bone in which fluid or another substance has created a central defect within a rock or a geological formation. Because the appearance is similar to that on an X-ray, these are called geodes. So remember age, location, the tumor bone tumor interaction, the matrix, presence or absence of a soft tissue component, and the size and number of lesions can be helpful in your radiographic assessment of bone tumors.